Welcome to today's congressional briefing entitled, Speaking with Keratoconus Patients About Research and Treatments, being held on World Keratoconus Day 2021. I am James Zerkowski, Executive Director of the Alliance for Eye and Vision Research, or AEVR, a 501c3 foundation that educates about the value of vision research and serves as the privately funded Friends of the National Eye Institute, or NEI, within the National Institutes of Health. This global briefing, held under the auspices of AEVR's Research Saving Sight, Restoring Vision Initiative, is being held in conjunction with AEVR member organizations, National Keratoconus Foundation, Research to Prevent Blindness, Eye Bank Association of America, and the Association for Research in Vision Ophthalmology, or ARVO, which along with Novartis has provided streaming support. I also wish to acknowledge Glaukos for its event management support. Since today is all about the cornea, which is the transparent front of the eye, I welcome Taylor Young, the Assistant Director of the National Keratoconus Foundation, based in Irvine, California, to offer a welcome and insights into challenges that keratoconus patients face. Welcome, Taylor.
Thank you, James. Hello, and welcome to this congressional briefing on the eye disease keratoconus. I'm Taylor Young, and I am the Assistant Director of the National Keratoconus Foundation. I am happy that you are joining us today. Thank you to our colleagues at the Alliance for Eye and Vision Research for putting this event together. AEVR's commitment to promoting the value of eye research has impacted millions of lives over the last 4 decades. We're honored to be their partner today. We've invited 2 of the country's leading experts, Dr. Christine Sint from the University of Iowa and Dr. Christopher Rapuano from Wills Eye Hospital in Philadelphia, to talk about their experiences as doctors who treat keratoconus. First, let me take a moment to tell you more about keratoconus and the National Keratoconus Foundation. As you'll learn, keratoconus is a disease that affects the shape of the cornea, the clear outer portion of the eye that is normally round and symmetric. For some people, usually during their teenage years, vision starts to change because the cornea tissue is weak. Things become blurry, they may experience double vision, and halos or streaks around lights. Keeping up at school or at work, participating in sports, and getting around at night or reading a computer screen becomes a challenge. These patients get frustrated because the glasses or contacts their doctors prescribed seem to work only a few weeks before the symptoms return. What is happening is that the cornea is continuing to change shape. The disease is progressing. As you can imagine, many people are misdiagnosed as having astigmatism or myopia and don't get the proper treatment. The National Keratoconus Foundation was founded 35 years ago by families affected by the disease. They wanted to raise awareness that this is not simply a refractive error that can be fixed with a pair of eyeglasses, but a lifetime condition that needs to be monitored. Since 2016, the National Keratoconus Foundation has been located at the University of California, Irvine, where we work with researchers and clinicians around the globe. We help promote promising clinical trials and other advances in management of keratoconus. We communicate with patients about the importance of avoiding eye rubbing on these fragile corneas. One thing that we've learned in the last few years is that there are far more people affected by keratoconus than we imagined. There are certain ethnic groups and geographic regions with a very high incidence of disease. Once thought to affect 1 in 2,000 Americans, the prevalence may be closer to 1 in 200 individuals. World Keratoconus Day is our effort to educate the public and to unify the global community of individuals touched by this condition. Dr. Rapuano will share information about a simple and remarkable treatment that strengthens the cornea collagen. The earlier the procedure is performed, the fewer vision complications a patient will face. Dr. Sint will give an overview of contact lenses for treatment of keratoconus. She will explain that advancements in contact lens technology that accommodates misshapen eyes has resulted in vastly improved vision correction and comfort. Getting a regular eye exam that includes screening for keratoconus if eyes are itchy or if there are unexplained vision changes is essential to early diagnosis and treatment. Thank you for taking the time to learn more about this disease and to help us celebrate World Keratoconus Day. To learn more, please visit our website, nkcf.org.
Thank you, Taylor. As Taylor noted, today's briefing features presentations by two clinicians who treat patients with keratoconus on a daily basis. Christopher Rapawano, MD, who serves as the chief of the Wills Eye Hospital Cornea Service and professor of ophthalmology at Sidney Kimmel Medical College at Thomas Jefferson University. He is an internationally recognized expert in keratoconus with a special interest in vision correction surgery, and Christine Zint, OD, who serves as the director, contact lens service, and clinical professor of ophthalmology and visual sciences at the University of Iowa Carver College of Medicine. She is one of the country's leading experts in the treatment and management of patients with severe keratoconus. Dr. Rapawano, welcome.
Thank you, Jim. I'm here today to talk about keratoconus, and I'm going to speak to you as if you're a patient being referred to me with the possible or the definite diagnosis of keratoconus. What is keratoconus? Well, keratoconus is a condition of the cornea. The cornea is the clear covering of the eye, a little like the top of a watch. Normal corneas are nice and round, a little like a basketball or a soccer ball, whereas keratoconus corneas are kind of thin and pointy, a little bit like a football kind of sitting on its end. The normal cornea has a nice round shape, like a basketball or a soccer ball, whereas a keratoconus cornea has an abnormal, kind of thin and pointy shape. I'm exaggerating a bit here, but that's the problem. When light comes into a normal cornea, it all gets focused on one point, giving good vision. When light comes into a keratoconus cornea, the light is all defocused, giving poor vision. And that's the problem with keratoconus. Who gets keratoconus? Well, it tends to come on around age 10 to 15 to 20. And it tends to be slowly progressive until about age 35, 40, 45. What are the risk factors for keratoconus? Well, keratoconus can occur in families, can run in families, so there's certainly some genetic risk factors. And I ask all patients, do you have any family members with keratoconus? And the second main risk factor, very important risk factor, is eye rubbing. Patients who rub their eyes a lot have a much higher risk of either developing keratoconus or making their keratoconus worse. So what I do is I ask all patients, do you rub your eyes a lot? And sometimes patients will admit that they rub their eyes, and I'll ask them, how do you rub your eyes? And sometimes they say, oh, I just rub a little bit like this, or sometimes they'll show me how they kind of grind their eyes. Any eye rubbing is bad. If they say, well, I don't rub my eyes at all, I will then ask their mother or father or significant other, does the patient rub their eyes? And oftentimes the patient will say they don't rub their eyes, but their significant other who's sitting there say, oh yes you do, you rub your eyes all the time. So patients often don't realize they rub their eyes. So I stress with them, don't rub your eyes. And I will often make a joke with the significant other, if you catch them rubbing their eyes, you can remind them not to, and they shouldn't blame you, but they should blame me. Because rubbing your eyes is really something that can make keratoconus worse, and there's not a lot we can do if people rub their eyes. Now, what's the treatment of keratoconus? Well, there are really two avenues of treatment. One is, how do we get your vision better, or vision? And the other is progression. Is it getting worse, and what can we do about it? As far as vision, it really depends on the severity of the keratoconus. Some keratoconus is relatively mild, and people can see well without correction, without glasses. In more common cases, sometimes glasses are helpful, or a soft contact lens is helpful. Usually, people with medium keratoconus or worse need a hard contact lens to give them better vision. What that does is it puts a nice smooth surface over their irregular cornea and can focus the light better. A hard contact can be helpful. If a hard contact either doesn't fit well or is too uncomfortable, the next step up is often a hybrid lens, hybrid being hard in the center with a soft skirt on the outside. That can sometimes be helpful. For greater comfort and stability, if that doesn't work, sometimes a patient will fit with a piggyback lens system, which is a soft contact lens on the eye, just to kind of protect the eye, and a hard contact lens that rides over that. So how do we help the vision? Well, a soft lens will just kind of go right along the surface and doesn't change the shape or the focusing of light, so it doesn't usually improve the vision very much. Most people with keratoconus benefit from a hard or rigid gasperal contact lens that puts a nice smooth surface on the cornea. In fact, that lens will kind of mimic a normal cornea and give excellent vision in most patients with keratoconus. But you can imagine this hard contact lens sitting on top of this pointy cornea, maybe a little bit uncomfortable, may not fit that well, so you have to go to an excellent contact lens fitter who does lots of keratoconus patients and is experienced in fitting patients with keratoconus. And then the newest, or not newest, but one of the more aggressive contact lens techniques for more advanced keratoconus would be a scleral lens. These are big lenses that kind of vault over the entire cornea, and they kind of touch the cornea touch the eyeball on the outside here and here, but they're really not touching the cornea, and then just saline or tears or fluid fills that space and can give excellent vision. These are large lenses that vault over the entire cornea, and they really just touch the eye on the very outside, not even the cornea, but kind of on the white part of the eye, on the conjunctiva. And those can be very, very helpful. I tell patients that if you're not happy with your vision, either without correction or with glasses, then you really need to see an excellent contact lens fitter like Dr. Simt, who can fit you for a contact lens. Contact lens fitting in keratoconus patients is trickier and much more time consuming than just a regular, ordinary, soft contact lens that most any optometrist can do. In some patients where contact lenses just don't work, occasionally you can reshape the cornea with tiny little plastic inserts called intracorneal ring segments. These are placed right in the body of the cornea, kind of around the center, and it can flatten and regularize the cornea to give people better vision, ideally without glasses or contacts, but really to get them so the cornea is more regular, so they're able to be better fit with contact lenses. Intracorneal ring segments work for occasional patients, but a lot of patients, it's really just not the best option for them. In occasional patients where contact lenses aren't successful, we can do intracorneal ring segments. These are small little plastic inserts that get put into the cornea that reshape the cornea. They look something like that. Sometimes one gets put in, sometimes two get put in, and they can occasionally work to give people better uncorrected vision, but oftentimes it gets people back into their contact lenses when they couldn't fit their contacts before. And then lastly, if contact lenses aren't working or aren't for the patient, in patients with severe keratoconus, perhaps with scarring, or where contact lenses just aren't able to be fit, then a cornea transplant can be done. That involves removing either 95% of the cornea or 100% of the cornea, and then replacing that with a new cornea and then stitching it into place. This can be very, very helpful in patients who just don't do well with other forms of keratoconus treatment. Having said that, transplants are not perfect and have rare, severe complications, so we try and avoid them whenever we can. I'll give a little bit more information on cornea transplants. In fact, about 95%, if not more, of patients with keratoconus who undergo cornea transplants get very good vision a year after surgery. Often they need glasses or contacts to get their best vision, but can do very, very well. These are patients who have significant keratoconus, not doing well with other treatments. They might have scar tissue, so even if they could wear a contact lens, the contact lens doesn't function. So we can cut here, and put a new cornea in there. And the new cornea then functions to give good vision. Now, the second avenue of kind of treatment or management of keratoconus is progression. For up until relatively recently, we had no treatment to stop progression of keratoconus other than telling people not to rub their eyes. Well, several years ago, procedure was developed called corneal cross-linking that does an excellent job to either decrease or ideally stop the progression of keratoconus. This is a procedure that we do in the office. It involves removing the surface layer of the cornea, creating a big scratch on the cornea, of course after putting anesthetic drops in and antibiotic drops in. And then riboflavin, special riboflavin vitamin B drops are placed in the eye for 30 minutes or longer. And then ultraviolet light is shined on the eye for 30 to 45 minutes, depending on the patient. We measure the cornea, make sure it reaches this magic number of 400 microns or 4/10 of a millimeter. And then we apply and shine an ultraviolet light on the eye for 30 minutes. And that chemical reaction strengthens the bonds in the cornea to the vast majority of the time prevent keratoconus from getting worse. And that can work very well to stop the progression of keratoconus. In fact, current cross-linking is about 95% successful in stopping progression of keratoconus. About 4% of the time, even after a cross-linking procedure, the keratoconus will progress. That might be because it was going to progress anyway, or maybe people are still rubbing their eyes even though they don't know it, or maybe they've got their hand under the pillow kind of rubbing their eyes at night and they don't know it. And then corneal cross-linking does have a 1% risk. At least the current iteration of cross-linking, which is the epithelium off cross-linking, where we remove the surface, there's about a 1% chance of a complication. That could be poor healing, which may cause scarring. There might be infection, might be swelling, there might be thinning. But that's the reason we just don't willy-nilly go and do cross-linking on anybody who has or might have keratoconus. We want to really wait till we know that we have some benefit of cross-linking, meaning that there's progression occurring and that it can then be treated with cross-linking. So we want to wait until we really think we have a benefit of cross-linking. For example, if there's progression, then we know we're using cross-linking to stop the progression. The cross-linking procedure is not static. In other words, research is ongoing as to how to make that procedure better, less painful, and faster. There are studies involving not creating as big or any scratch on the cornea. Additionally, shorter times to put in the riboflavin and shorter times of ultraviolet light. So those would be potential advances in performing cross-linking, but those studies are currently ongoing. Now in your case, where do we go from here? Well, as I said, the next step would be correction of your vision. Depending on how good or bad your vision is, you might get glasses, or we might refer you to an excellent contact lens specialist like Dr. Sint. As far as progression, we would like to determine whether your keratoconus is getting worse or not. Sometimes we have records from your doctor, and we can then compare your records to our records today. As you know, today we did corneal mapping on you, where we used several different machines to evaluate and analyze the shape of your cornea and your corneal thickness. And depending on how the maps today compare to previous maps that you've provided us, we can determine whether your keratoconus is getting worse. If you don't have previous maps and we're not sure whether your keratoconus really is getting worse, then typically what we would do is we would schedule a visit to see us back in 4 to 6 months. We'd repeat our mapping, our corneal curvature maps in 4 to 6 months, and we compare them to today. And if we notice they look like they're stable and your vision is stable, we would hold off on a corneal cross-linking treatment. However, if we decide that your vision is getting worse and or your maps are getting worse, then we would suggest that you proceed with a cross-linking procedure. We'd like to do the cross-linking at a lower stage or a milder stage of keratoconus, where we can stabilize it at a milder stage where your vision is still pretty good, versus waiting until it gets to be really bad and stabilizing it at a much worse stage. Additionally, we need a certain corneal thickness to do the current FDA-approved cross-linking procedure. It needs to be around 400 microns thick, ideally before the procedure, but certainly in the middle of the procedure before we can proceed with cross-linking. 400 microns is 4/10 of a millimeter, whereas a normal corneal thickness is about 500 and 550 microns. As I mentioned earlier, keratoconus corneas are thin and pointy, so they already start off thinner. But if you start off much lower than 400 microns, it's difficult to complete the cross-linking procedure. So at this point, I'd like to hand you off to my colleague, Dr. Christine Sint.
My name is Dr. Christine Sint. I am a clinical professor of ophthalmology and director of the contact lens service at the University of Iowa. As an optometrist, I didn't set out to have a career in keratoconus, but it seems to have found me. I remember applying for a grant about 25 years ago and being told it was too much of an orphan disease. But today, through better education, better diagnostic technology, we realize, as Dr. Rapuano suggested, it's not an orphan disease. Rather, it's quite prevalent. As a matter of fact, I say everyone either has keratoconus or is just waiting to get keratoconus. Keratoconus affects lives. A keratoconus diagnosis brings on the fear of the unknown. Am I going to go blind? Will I have to have a transplant? And because it most frequently starts in young people, questions of career and independence abound. I remember one young lady early in my career sitting in my chair, having dropped out of school, and asking me, "So what's next? I'm at a crossroads. Where do I go from here?" That question, what's next? Where do we go from here? It's affected my entire career. Not only as a clinician, but as an educator, an inventor, and as a mom. As a clinician, it's my job to create good interpersonal relationships with the patient so that we may exchange information and make treatment-related decisions. Essentially, create a roadmap. Where have I been and where am I going? To do this, I need the most up-to-date information, as well as time and funds to carry out those treatment plans. Treatment plans are no longer top-down, doctor to patient, but rather a partnership for compliance. As an educator, not only do I need those most up-to-date information, but I also need a way to disseminate my knowledge. Both colleagues and patients consume information differently than in the past. While peer-reviewed literature is still very important, there is a strong influence from social media and online support groups. It's often exhausting trying to keep up with it all. As an inventor, where are we going is the big question, maybe the driving question in everything we do. It's not okay to tell a patient there's nothing more that can be done. Hope is what keeps us going. Invention is the what's next in this disease. Invention is done in the trenches with the people who see keratoconus every day. Keratoconus hit too close to home when I diagnosed my son with keratoconus at age 20. Funny, but everything I know about this disease, everything I have taught, everything I have invented, and everyone I know could not protect the people I love most. As a mom, I had all the same fears. What's next? Where are we going from here? I remember my son saying to me, "But Mom, I don't want this. Make it go away." And I can't.
Hi, my name is Benjamin Sint, and I relate to the doctor because she gave birth to me. About the time around when I turned 21, she noticed some drastic changes, and it turns out I was diagnosed with keratoconus, and thanks to her connections here at the hospital, I ended up getting surgery later on that year for both eyes. People that are maybe in the beginning stages, I'd say go to your doctor early and often. The surgery is really expensive and not really covered by insurance, so if you catch it earlier, you're more likely to save your vision and your money. For people that do have it, I'd say just get used to changing your prescription a good amount and getting used to the new normal. Since having surgery, it stopped getting worse, but that doesn't mean it made it better, so I still don't see well. I can see fine enough, when I wear my contact lenses, but I've been in a cycle of switching between hard lenses and soft lenses every couple months for the last 3 years, just trying to find the balance, because the soft lenses are a lot more comfortable, but I don't see as well. But then in the hard lenses, I see better, But if they fog up constantly or something gets under it and they get dirty, and if I'm out driving somewhere, that's a dangerous hazard for me. So it's been a tough balance of trying to find a good lifestyle fit. Currently, that's not what I'm wearing, but I was wearing it the previous about 3 months or so. Since my eyes are weirdly shaped, she's been going in and out of designing like new shapes to cover out the sclera on the outer sides of my eye. But right now we're in the process of back to soft lenses for a little while because school just started again, and I need a little bit more leisure of lifestyle as I adjust back to school and everything. So those specially made contact lenses, for people that don't know, they take the mold of your eye, a 3D scanner scans it, and then they put it into a 3D modeling software, and then that model goes to a lathe to cut it. But that contact lens can last about a year or so. That's what about the average person uses it for. Obviously, you have to deeply clean it every day because if you're using something on your eye that long, you don't want bacteria to grow. So there's big hassles there. But what I'd say to everyone in general, don't rub your eyes. That's probably the big reason why I got it, especially when you're younger, when you're developing. This is the bigger growing problem between, people under the age of 30 or so. Keratoconus, if you think of your eye, I don't know, think of it like this type of shape, it like kind of sags. So the whole the eye is specially designed, like think of it like a dome for like light to come in and hit the back of your eye. If it gets off kilter like that, the light's not going to get through and everything's going to be, fuzzy and chromatic aberrations and whatnot. That's not really the layman's term, but it's just going to vastly change your vision, even though like nothing on the inside's changed. It's like the outside is damaged. And it's nice knowing that she's one of the top specialists in the country because even she has difficulty with my eyes. So that means like if she's one of the top doctors, then like that means other people would struggle just even more. So I don't know. It's nice because since I have like such difficult eyes, it's also a good learning experience for her to translate it to hundreds or thousands of others patients in the future for research purposes. Honestly, it took me a while to adjust to it because based off scheduling, I just can't do spring break, and that was a big thing at the time, just turning 21. But it wasn't the hardest thing because I had to learn how to put in like sclera lenses, which is for most people much more difficult. But having my mom be my teacher and teach me at home, that helped to ease the transition a bunch. I don't know, it wasn't as bad just because my mom's so experienced in it. She was able to explain all the steps along the way, so it's not like I was ever lost. I was guided the whole way.
So, as clinicians, educators, inventors, and parents, we have to build on what we know to create the what's next. With keratoconus, the vision is distorted by a bump or irregularity on the cornea, the front surface of the eye. When a stiff piece of plastic is placed on the cornea, those bumps are covered up, creating a new, smooth surface. This allows for the light to bend evenly and a clear image to be formed. Contact lenses have been the mainstay for vision improvement for keratoconus for nearly a century. Prior to World War II, contact lenses were made from hand-blown glass and experienced little popularity. However, during the war, German officers were not allowed to wear glasses while in uniform, so the interest in contact lenses soared. And after the war, Allied servicemen carried this information home, and an industry was born. Since optically active glass was very expensive immediately after the war, there was a switch over to plastic. An impression was taken from the eye using alginate, a plaster-like substance, and the plastic was then melted or vacuum sealed over that eye mold. And while these lenses were quite comfortable, they did not transmit any oxygen and could only be worn for limited periods of time. So, out of necessity, lenses started to get smaller and smaller and smaller until they rested only on the center part of the cornea. Even then, oxygen transmission was a problem, and frequently, lens intolerance was an issue. And although soft contact lenses debuted in the early 1970s, oxygen transmissible materials for the correction of keratoconus did not come until the early 1980s. And while oxygen transmissible materials helped, they did not solve the discomfort issue. So, in the late 1990s, when hyperoxygen materials came out, there was yet another revolution in keratoconus care. As we moved forward, we looked back at that extreme comfort of those scleral contact lenses. So what are people using today for irregular corneas? Well, the vast majority of people in 2021 are wearing scleral contact lenses, followed by gas-permeable lenses. When we look at what drives what people choose for contact lenses, it really isn't just the optical quality. Almost all contact lenses have fairly good optical quality at this point, but those non-visual factors like the fit, the comfort, and the cost may drive the choice of people who have keratoconus. So when it comes to contact lens fitting for keratoconus, there are some barriers. Emotion and money make medical contact lens fitting very complex. Before I can fit someone into a contact lens, I have to understand who that person is, what makes them tick, and what expectations they have. I always say fitting the eyeball is much easier than fitting the person. During the exam, I am listening for your level of acceptance of the disease, your emotional state. What will bring quality to your life? What are your expectations and goals? I want to know what you already know. I want to know you. There are certainly costs associated with keratoconus. Exam fees, like office visits, fitting fees, imaging, and material fees, like the cost of goods, shipping and handling, restocking fees. But there are also hidden costs, like the number of visits, travel, time out of work, remakes, and cleaning supplies. And there's also a cost of discomfort and poor vision, like lost wages, emotions, and anxiety. So we take all of these things and we develop a care map, and together we define what success will look like. Through the whole fitting process, we discuss other medical care involved, like cross-linking, treatment of dry eye, lid surgeries to hold the lids up. We discuss the number of follow-ups that's necessary to bring about success. So where are we in 2021, and where are we going? We know that the eye is not round, and we have ways of measuring the eye, and we can create contact lenses that are not round. So this leads us back to where we were 100 years ago, understanding the ocular shape based on collection of data from the eye itself, and creating a contact lens that is the same shape as the eye. This allows us to put on advanced optics on the lens. It allows us to move those optics around. It allows us to put multifocals and prisms and higher order aberration corrections on the lenses. Where are we going? Smart contact lenses to create heads-up displays and vision enhancements. I'd like to talk about a case report of one of my patients, a 59-year-old female with moderate keratoconus. She has corneal scars and early cataracts. Her habitual contact lens was a small diameter contact lens, and she had vision of about 2100, meaning she could see at 20 feet what a normally sighted person could see at about 100 feet. Over time, her comfort decreased. She had increased complaints of dryness, reduced wearing time. We actually tried to piggyback the lens, putting a soft contact lens under that hard contact lens to give her better vision, but she felt like it degraded her vision and wasn't worth the hassle. So we designed one of these scleral shape optimized lenses, and her best corrected vision went to 20/40, and she thought that was amazing, but she still had residual coma and trephyle. Those are higher order aberrations. So we corrected those on the front surface of her contact lens, and she was actually 20/20. She could see at 20 feet what she was supposed to see at 20 feet. So as a clinician, an educator, an inventor, and a mom, I know there are so many opportunities to improve the patient experience, to prevent this disease, and to improve outcomes. So the real question is, what's next? Thank you for your attention.
Thank you, Dr. Zint. AEVR wishes to thank our speakers and co-sponsors for their engagement in this important education, especially Glaukos for management support and Arvo and Novartis for streaming support. Note that AEVR will stream a Thyroid Eye Disease Awareness Week 2021 congressional briefing on Wednesday, November 17th at 12 noon Eastern. More information can be found on the AEVR website at www.eyeresearch.org. Thank you.